If you're studying for the INBDE, I highly recommend INBDE Bootcamp, an all-in-one study resource that will help you pass your exam. Use coupon code MENTALDENTAL for 10% off. Welcome to this brand new series on oral diagnosis. I'm really excited about this one, guys. If you've watched my oral pathology series before, this is basically an updated, expanded, and improved oral pathology 2.0. It's bigger, it's better, with an emphasis on the proper recognition and diagnosis of intraoral and extraoral lesions and conditions. And as always, I'll be focusing only on the high yield things that you need to know for your board exam. Speaking of which, the INBDE is broken up into 10 foundation knowledge areas, or FKs. You can see them listed at the top of this table here. I'm primarily tackling FK7 with this oral diagnosis series, which you can see accounts for approximately 11% or 55 of the total 500 questions you'll get on the INBDE. This information is extremely applicable, though, to a host of other exams, including the ADAT, AFK, DL OSCE, NBDHE, and many, many more. In the bottom right here is a quick look into the specific basic science categories covered in this foundation knowledge area 7. As always, these subjects will be combined with the important aspects of dentistry to make the exam clinically relevant, including diagnosis and treatment planning, oral health management, and practice and profession. Okay, so we'll start this series talking about developmental disturbances or anomalies that happen during growth and development. And I've broken this subject down further into the specific tissues that are involved. Since this is mental dental after all, we're going to have to start with the teeth. And we'll cover anomalies in tooth number, size, shape, and finally, structure. Congenitally missing teeth. So this means missing a certain number of teeth from birth. That's what congenital means, from birth. Hypodontia is the congenital absence of 1 to 5 primary or permanent teeth. Note that this does not include missing third molars, otherwise known as your wisdom teeth. So, for example, if you're only missing tooth number 1, you do not have hypodontia because that missing wisdom tooth does not count towards your total. Oligodontia is one step further, and it refers to the absence of 6 or more primary or permanent teeth. Once again, missing wisdom teeth do not count toward that total. Some resources misquote this definition as having more than 6 missing teeth, meaning 6 would actually fall under hypodontia. Many textbooks and peer-reviewed research articles agree that 6, 7, 8, and beyond would fall under oligodontia. So that's what I subscribe to, what I have on this slide here. This condition can occur alongside a syndrome such as ectodermal dysplasia. Those two often coincide with each other. Anodontia is defined as the absence of all primary or permanent teeth. And having complete anodontia like this is very, very rare. And it usually occurs as part of a syndrome like, once again, ectodermal dysplasia. For a simple way to remember the most likely missing teeth, just count down 3, 2, 1. 3 is for your third molars. Those are the most likely missing teeth. 2 is for the mandibular second premolars. And 1, well, it's a little bit of a stretch, but the word lateral has 2 L's in it. It starts and ends that way, and 1 kind of looks the same. So that's how I remember that one. By the way, the most common congenitally missing primary tooth, which is very rare, is the primary maxillary lateral. So this one shows up again when we're talking about the primary dentition. We can also have the opposite problem and have too many teeth, which is called supernumerary teeth. Hyperodontia is the medical term for having extra supernumerary teeth, and this could be just one extra tooth or multiple extra teeth. Around 3% of the population will have at least one extra permanent tooth, and about 0.5% of the population will have an extra primary tooth. So once again, it's more rare to mess with the number of primary teeth. Supernumerary teeth may cause some issues by blocking the normal eruption of permanent teeth, and sometimes it's necessary to take these out to prevent impaction of the normal permanent teeth. Just like multiple missing teeth is associated with ectodermal dysplasia, multiple extra teeth is associated with a condition called cleidocranial dysplasia. The most common type of supernumerary tooth is a mesiodens, which is an extra tooth specifically located at the midline between the two maxillary central incisors. Most of them are palatally positioned, but note that supernumerary teeth don't always erupt through the gingiva, and sometimes they stay stuck beneath the surface. The next most common supernumerary tooth is a paramolar, which is an extra molar. I suppose you could call it a fourth molar, and it's usually very small and located either buccal or palatal to one of the maxillary molars. Before we continue, I have to tell you about this incredible AI study tool that will help quiz you on what you're learning in this video, and it's called Wisdolia. It'll give you an outline, flashcards, and even case scenario questions customized from this video. And as you answer the questions, you'll get personalized feedback to tell you exactly what you got right, what you got wrong, and why. You can find the Wisdolia link in the description below. Now, back to the video. Here are two fun words describing how many sets of teeth you have. A diphyodont is any animal with two sets of teeth, a deciduous or primary set, and eventually a permanent set. Most mammals, including humans and lions, are diphyodonts. A polyphyodont is any animal whose teeth are constantly replaced, like sharks and crocodiles. With regards to the pattern of dentition, hypsodontia, not to be confused with hypodontia, is a pattern of dentition with high-crowned teeth, providing extra tooth material for wear and tear. All animals that feed on gritty, fibrous material like cows and horses tend to have these kind of teeth. Interestingly, hypsodont teeth erupt with a layer of cementum covering the entire tooth surface, but it's quickly worn away from the crown over time because, as we know, cementum is much weaker than enamel. The opposite to that is brachydontia, brachy meaning short, and it's a type of dentition that is characterized by low-crowned teeth. Dogs, cats, and technically humans are considered brachydonts. Okay, now we're talking about tooth size. So microdontia refers to smaller than normal teeth. We can have localized or isolated microdontia, which is actually fairly common. A peg-shaped maxillary lateral incisor is the most common microdont tooth. We can also, though, have generalized microdontia, where all the teeth are smaller than normal. This is much less common and usually associated with some type of syndrome, including Down syndrome, pituitary dwarfism, or ectodermal dysplasia. Remember these three D words for downsized teeth. We have Down syndrome, pituitary dwarfism, and ectodermal dysplasia. D for downsized. Macrodontia is the opposite issue, bigger than normal teeth. And this excludes fusion or gemination, which we'll cover in the next slide. This can be localized or isolated to one or a few teeth, like here, or can affect the entire set of dentition, like on the right. Pituitary gigantism and Rabson-Mendenhall syndrome are examples of syndromes associated with generalized macrodontia. You can remember a gigantic rat running down the hall. That's a pretty terrifying image, and you can imagine a giant rat having some pretty giant teeth to go along with it. Developmental anomalies. Here are 4 anomalies during a tooth's development that we can conveniently group together. Starting from the left, we have gemination. Gemini in Latin means twins. It's also a zodiac sign, but it's not quite the same as twinning, as you'll soon see. Gemination is where you have one tooth bud that partially splits, so you have a larger than normal tooth with a bifid crown. And there's also a larger than normal shared root canal as well. So one tooth bud still becomes one tooth, but it's a little bit misshapen. It most commonly affects the maxillary anterior teeth. Since we're not gaining or losing any teeth, I'm going to use the letter N here to represent, well, we still have a normal amount of teeth. Next, we have twinning. And twinning is essentially a complete gemination, where that one tooth bud completely splits into 2 teeth. So twinning would actually create a identical mirror image supernumerary tooth in that arch. So now we could say N, but now we have +1. We get an extra tooth added to the equation. Next, we have fusion, which is sort of the opposite issue. We have 2 tooth buds next to each other that end up fusing at the dentin layer, as well as the cementum and enamel layers, to create one very large tooth, but with separate pulp chambers, pulp canals, and roots. Remember this rule, by the way: the earlier that an anomaly takes place during tooth development, the more severe the ultimate outcome will be. So if this fusion occurs really early in the bud stage of tooth development, we'll get a complete union of these 2 tooth buds. But if this fusion occurs later during the cap stage of tooth development, this will be more of an incomplete looking union. Regardless, we count this whole thing as one tooth. So we actually end up with one less tooth than we would expect, because 2 tooth buds technically become only one tooth. This is more common in primary teeth and almost always involves incisors. And lastly, we have concrescence, where 2 tooth buds create 2 separate teeth, but those teeth fuse at the cementum layer only. So it's a union of 2 distinct teeth at the cementum layer. So we would still wind up with a normal number of teeth because 2 tooth buds still became 2 individual teeth. This is most common with the maxillary molars. So with that, take a moment and, based on what we learned in the last slide, assign the correct term for each of these 3 images. You can pause the video if you want to, and then I'll give you the answers. Okay, so on the left, we have gemination of maxillary central incisors. So we have a normal tooth number, N, but we have misshapen bifid crowns. There's this little kind of split going down the center of the tooth. In the middle, we have fusion of 2 mandibular primary incisors, because we only have 1, 2, 3 incisors, and these are canines. So we have one less tooth than we would expect because both of those tooth buds became one tooth. So we're left with N minus 1 teeth. And on the right, we have concrescence of two maxillary molars where they fused together at the cementum only. And that would result in a normal number of teeth. Hypercementosis. Hyper means extra. Cementosis referring to the cementum. So hypercementosis refers to the excessive deposition of cementum on the tooth roots. In most cases, its cause is unknown, but it can be related to supraeruption, inflammation, or Paget's disease of bone. It's also sometimes associated with concrescence, where, as we just learned about, the cementum of two adjacent teeth fuse together. You can remember these three possible contributing factors with the silly mnemonic sip on cement. I certainly do not ever recommend sipping on cement, but for the purposes of remembering, let's just imagine those tooth roots getting thicker and thicker as we sip on cement. By the way, research has shown that hypercementosis tends to be most common in molars, but some authors have found premolars to be the most commonly affected teeth. So there's some disagreement there. My understanding is that it's most common in molars, mandibular molars specifically. And also keep in mind that most teeth with hypercementosis tend to be vital. An enamel pearl is a hard spherical lump of enamel that develops on the root of a tooth where it doesn't belong. The problem with this is it cannot be scaled off because it's literally a glob of enamel fused to the cementum. And it blocks the attachment of Sharpie's fibers, which are type 1 collagen fibers of the periodontal ligament that connect the alveolar bone and the cementum. So with that enamel in the way, the patient will automatically have a periodontal pocket where that pearl is, and bacteria can wind up collecting in that pocket. Enamel pearls also only occur in molars. Dilaceration refers to an abnormal bend in the root of a tooth. Usually, each root of a tooth will be fairly straight and follow a linear axis, but sometimes the tip of a root will deviate in a certain direction. In anterior teeth, dilacerations tend to be in a distal direction in the apical third of the root, and in posterior teeth, where it's frankly more common, dilacerations tend to be in the middle third of the root. As with many of the conditions we've talked about so far, permanent teeth are much more commonly affected. So how does this root bend happen? Well, usually it's the result of traumatic injury to a primary tooth. So if a primary tooth gets traumatized and bumps into the developing permanent tooth underneath, that root might change direction while it's developing. Dilacerations don't do very much, but they could complicate endodontic treatment, orthodontic treatment, or in the event that the tooth has to be extracted, extraction treatment. Ankylosis is when two mineralized surfaces fuse together. For tooth ankylosis, that would be cementum and alveolar bone fusing together following either damage or degradation of the periodontal ligament. It could be secondary to trauma, inflammation, infection, or just a genetic predisposition. So why does ankylosis matter? Well, once ankylosis happens, that tooth can no longer erupt naturally or even move orthodontically. And because eruption brings alveolar bone with it, ankylosis leads to the arrested development of the alveolar ridge. So you get this massive bony defect. Of course, it's much worse the earlier that ankylosis occurs during the eruption process. Signs of an ankylosed primary tooth include an occlusal step between that and the neighboring teeth, a hollow sound on percussion, and a depressed bone level. This occurs more often in the mandible than the maxilla, and more commonly in the primary dentition than the permanent dentition. Primary molars specifically are the most often ankylosed teeth. Now, there is some disagreement in the literature regarding primary first and second molars. Based on what I've seen in the clinic and in the literature, I believe primary second molars are the most common ankylosed tooth. That matches nicely, by the way, with mandibular second premolars, which usually replace those mandibular primary second molars, being the most common permanent missing teeth behind wisdom teeth. And you can see right here in this radiograph, there is no permanent second premolar to replace that tooth. May have contributed or been a factor in why that tooth became ankylosed in the first place. Dens evaginatus. So this literally translates as an evaginated tooth. And evagination refers to a process of turning outward. It manifests as an extra or accessory cusp. It's referred to as a talon cusp when it's on the lingual surface of an incisor, and if it occurs as a fragile projection on the occlusal surface of a lower premolar, that tooth is called Liang's premolar. Now, these are real cusps, so they have pulp horns following underneath. Therefore, be really careful with operative procedures. You can't just polish a dens evaginatus off because there is likely pulp tissue following the contour of that cusp underneath there. Dens invaginatus is the opposite. It's caused by invagination or turning inward of the inner enamel epithelium layer during tooth development. The problem with this is caries can progress very quickly through the caved-in enamel that basically creates a tunnel for bacteria to get through. Radiographically, it looks like a small tooth within the main tooth. And sometimes this condition is called dens in dente, which is literally what that means. It most commonly affects the permanent maxillary lateral incisor, as you see here in all three of these images. By the way, you do need a radiograph in order to definitively diagnose this condition. Taurodontism. So we already talked about Gemini before with gemination, and another zodiac sign is Taurus, which means bull. So taurodontism literally means bull teeth. But what does that mean? Well, remember we talked before about hypsodontia with tall crowned teeth? Well, these teeth look taller than usual, and it's because their crowns and root trunks are elongated. And the root trunk, by the way, is the area from the cemento-enamel junction to the furcation where those roots split off from one another. So it leads to vertically elongated crowns, root trunks, and pulp chambers at the expense of the roots, which become a lot shorter by comparison. All right, the next three conditions are going to be affecting the enamel layer, and they go from mild to moderate to severe in terms of their effect on enamel structure. Enamel hypocalcification refers to an abnormal mineralization that happens pretty late in tooth development, so the ultimate effect is relatively minor and usually only cosmetic. This less than normal calcium deposition interferes with the normal translucency of enamel, resulting in these chalky white spots, or sometimes yellow-brown spots. If the patient wants, these can usually be fixed by some conservative restoration or a more advanced whitening technique. Enamel hypoplasia is next. Hypoplasia means that something has a less than normal number of cells. So basically, Enamel hypoplasia is an underdeveloped enamel layer with missing tissue. Two specific examples of this include Turner's hypoplasia and congenital syphilis. With Turner's hypoplasia, the affected tooth is called Turner's tooth, and it has a yellow-brown discoloration on the facial surface, and this has to be a permanent tooth. Why? Because it's the direct result of a periapical infection or trauma to a primary tooth that caused an inflammatory response that messes up the ameloblasts of the developing permanent tooth underneath. The ameloblasts are what make the enamel. So a primary tooth gets bumped or infected, and that messes up the developing permanent tooth underneath, which gets this hypoplasia. It most commonly affects central incisors and premolars. Congenital syphilis is a version of syphilis acquired by a baby from its mother who has syphilis. This would occur in the uterus before birth. Hutchinson's incisors refer to incisors with a hypoplastic notch in the incisal edge, and mulberry molars refer to molars with this globular enamel on the occlusal surface with many small cusps. Both of these features are pretty characteristic of congenital syphilis. Amelogenesis imperfecta. Amelogenesis is the process where a protein-rich matrix is laid down and then later replaced by hydroxyapatite crystals, and this results in the highly mineralized enamel that we're used to seeing. Amelogenesis imperfecta is when that process goes imperfectly, so to speak. The next three conditions that I talk about, by the way, amelogenesis imperfecta, dentinogenesis imperfecta, and dentin dysplasia, are all hereditary conditions that affect all of the teeth, primary and permanent teeth. And they're all inherited by an autosomal dominant pattern. Although amelogenesis imperfecta can also be inherited less commonly by an autosomal recessive or X-linked pattern. Amelogenesis imperfecta causes intrinsic alterations of the enamel structure and leads to yellow-brown discolored teeth with little to no enamel noticeable on the radiograph. But the dentin and pulp remain unaffected, and they're pretty normal. So the good news is you can save these teeth with a really strong restorative treatment plan, usually involving full coverage crowns. There are 4 distinct types of amelogenesis imperfecta. There's some overlap with what we've already talked about, which is helpful, but let's go through these systematically. Type 1 amelogenesis imperfecta is the hypoplastic type, and thankfully we already know what hypoplasia means. That is enamel that is underdeveloped. So the crowns of these teeth may actually be smaller than normal because we have less enamel, which could lead to an anterior open bite where these front teeth do not come together. The teeth are also often discolored. They might be off-white or have a yellow-brown appearance. You do have a normal enamel hardness, but the amount and or color is not normal. Type 2 is the hypomaturation type, where the enamel lacks maturation of its crystalline structure. So it's usually discolored, but also with a pitted texture with all these pits in it. It can also be more brittle and prone to fracture. A rare version of this can lead to what are called snow-capped teeth, where the teeth are really chalky white and opaque. Type 3 is the hypocalcified type. It's similar to type 2, but the enamel is also really soft. So these teeth can wear down very quickly through attrition and abrasion. And calculus tends to build up very quickly on these teeth. Lastly, type 4 is a combination of type 1 and 2, where the teeth are small and they have pits, And we get Taurodontism with the elongated pulp chambers and all of those fun things we talked about already. How I remember the order of these is P for plastic, M for maturation, C for calcified, PMC, which of course stands for PubMed Central, which is a hub for biomedical literature where you could certainly read about Amelogenesis imperfecta. So Dentinogenesis is the formation of dentin by odontoblasts. So Dentinogenesis imperfecta is when that process goes wrong or imperfectly and causes an intrinsic alteration of dentin. Clinically, this usually manifests as translucent blue, gray, or amber colored teeth. And radiographically, you often see short roots, bell-shaped bulbous crowns due to a constriction at the cemento-enamel junction, and obliterated pulps where you can't even see them on the x-ray. Primary teeth tend to get affected more severely than permanent teeth. And there are 3 distinct types of Dentinogenesis imperfecta. Type 1 occurs in people who also have osteogenesis imperfecta, which is a similar condition in genetic origin, but also causes blue sclera, usually the white part of the eyes, and brittle bones, and sometimes hearing loss as well. Type 2 Dentinogenesis imperfecta is a dentin abnormality only. So there's no bone disease here, there's no blue sclera, it's just the intrinsic alteration of dentin. Type 3 Dentinogenesis imperfecta is pretty unique. It's called the Brandywine type, and it's not because the teeth are wine-colored. It's because this disorder seems to be isolated to a group of individuals in southern Maryland in a town called Brandywine. And these teeth tend to be very weak with thin dentin layers, and they can be called shell teeth, especially those primary teeth. And the features that differentiate it from the other 2 types include multiple pulp exposures, periapical radiolucencies, and this unique radiographic appearance. Dentin dysplasia is similar to Dentinogenesis imperfecta in that both conditions are inherited by an autosomal dominant pattern, all of the teeth are affected, and both also involve abnormal dentin formation. But with this condition, there are fortunately only 2 types for us to learn. Dentin dysplasia type 1 is the radicular version, and it's called that because it primarily affects the roots of the teeth, while dentin dysplasia type 2 is the coronal version because it primarily affects the crowns of the teeth. Type 1 is the more common version of the 2, and it features very short roots, sometimes resulting in what we call rootless teeth. So you can imagine, without roots, you get premature mobility and exfoliation of those affected teeth. We also tend to see obliterated pulps and pulp stones, which lead to what we call crescent-shaped or chevron-shaped pulp chambers, or perhaps no pulp chambers at all. This is what a chevron symbol looks like for reference. There tend to be a lot of periapical radiolucencies, or PARLs for short, as you can see in this panoramic radiograph. There tends to be a slight amber translucency to the crowns, but otherwise they actually look fairly normal. You can imagine these teeth, though, are unfortunately not good candidates for restoration, thanks in large part to their rootless nature. Type 2 is the less common version, and it's basically a variant of Dentinogenesis imperfecta that mostly affects the primary teeth. The permanent teeth are actually normal in color, shape, and height. However, noticeable on the radiographs, they tend to have enlarged pulp chambers that are constricted near the base with really thin root canals. And this results in a pulp shaped like a thistle tube, which is a piece of lab glassware that I've depicted here. And you can see what they're referencing with the wide enlarged pulp chambers that constrict very narrowly to a very thin pulp canal. And that matches the shape here, also noticeable in the posterior teeth as well. And lastly, we have regional odontodysplasia. This is a non-hereditary condition, so it is not genetically passed down. And it also has a very distinct presentation. It affects the ameloblasts, which make enamel, the odontoblasts, which make dentin, and the cementoblasts, which make cementum, but only in one quadrant of the mouth for both dentitions, primary and permanent. So it causes this extremely disorganized growth of all dental tissues in that one quadrant, creating what are known as ghost teeth. This is really important for you to know that term related to this condition. Ghost teeth radiographically, as you can see, have very thin, hard tissue, massive pulp chambers, open apices, short roots, and these are unfortunately just a mess. They don't last very long, but they do bring healthy alveolar bone as they erupt. So the goal is to support eruption of these teeth for as long as possible and then ultimately extract them in the affected quadrant. That's it for this video lecture. Thank you so much for watching. I genuinely appreciate it. I'd also really appreciate if you consider clicking that like button below this video, subscribing to the channel if you have not already, sharing this video with your friends, and leaving a comment below letting me know what you thought. All of those things can really help to grow the channel. If you want to go above and beyond supporting me and what I do here, please check out the Patreon page linked below. If you want to join there, you'll get access to exclusive practice questions, exclusive study guides, a Discord server, and so much more. And if you see at the end of my videos, I have an end credits screen, and all of those names there are the names of my amazing Patreon supporters that I'm honored to have. Thank you again for watching, and I'll see you in the next video.